Good morning, everybody. We will get started. Welcome to our third installation of Senior Grand Rounds, where we have two more excellent senior residents here today to present for us. We're going to get started with Dr. Sona Manjunath, who is from Lake Jackson, Texas. She did her undergraduate studies at the University of Texas, Dallas, where she studied biology, and then went over to UT Southwestern Medical Center for medical school. She's now finishing her internal medicine residency here at WashU and is applying to a cardiology fellowship. Her ultimate plans are to pursue advanced training in heart failure and cardio-oncology, and very aptly so, she has is going to talk to us today on heart failure disparities. So please welcome Dr. Manjunath.
Great. Thank you for that kind introduction. Hello, my name is Sona Manjunath. Thank you, Dr. Gage and Dr. Costco, for inviting me, and thank you all for being here. I'll be talking about the complexity of racial disparities in congestive heart failure. So I don't have any financial disclosures. And here's the outline for my talk. It's pretty simple. We'll highlight racial disparities observed in heart failure. We'll understand why these occur and discuss possible solutions. At the end, my goal is to convince you that we have miles before us in mitigating the gap of racial disparities, specifically in cardiovascular diseases and heart failure. So heart failure is the fourth leading cause of hospitalizations and leading cause of hospitalization for cardiovascular conditions in the US. 80% of medical costs related to heart failure result from inpatient care. African Americans have the highest risk of heart failure-related death, as demonstrated in the figure above. The graphs depicted have time in the x-axis and heart failure-related cardiovascular death rate in the y-axis. In the left, we see mortality being highest in African American males, depicted in the blue line. We see this also detected in the right graph for older adults 65 to 84 years. The rate of hospitalizations for African Americans is 2.5 times higher than for Caucasians. While the relative rate of hospitalizations has decreased for other race and ethnic minorities, this is not present for African American patients. The coronary artery risk development in young adults, or CARDIA, is a 1985 study which followed a diverse group of individuals for 25 years. The study showed that there was significantly higher burden of heart failure-related mortality among young and middle-aged African Americans, resulting in significant years of life lost before age 65. Specifically, there was a 20 times higher incidence of heart failure among African American men and women at an average age of 39 years. Incident risk of heart failure in African Americans was predicted by the presence of modifiable cardiometabolic risk factors, including hypertension, hyperlipidemia, chronic kidney disease, and high BMI. How is inpatient care affected? In a large national sample of heart failure ICU hospitalizations, African Americans were less likely than Caucasians to receive primary ICU care by a cardiologist. Specifically, the findings demonstrated that Caucasians have more than a 40% increased likelihood of receiving care. Prior studies have demonstrated nearly 90% increased likelihood of a heart failure patient receiving cardiology care if the individual was Caucasian instead of African American. Primary ICU care by a cardiologist compared to a non-cardiologist was associated with higher in-hospital survival irrespective of race. Because African Americans have a higher risk of progression of left ventricular systolic dysfunction than Caucasians, there's a greater need for specialist care and advanced therapies evaluation. Medicare expenditures by race after hospitalization for heart failure is another landmark trial which focuses on the cost burden of these disparities. At 1 year, Medicare costs were highest for African American patients, with Medicare Part A paying about $10,000 more per beneficiary. You can see this in the graph depicted. The African American population is depicted in the black line, and the Caucasian population is depicted in the dashed line. As you can see, the discrepancy is about $10,000 more for African American patient compared to Caucasian patient. The higher use of acute care services are driven by higher admission and 30-day readmission rates. Improved treatment of manageable comorbidities may reduce the acute care service repeated use in this population. We'll now explore special populations, specifically cardio-obstetrics and cardio-oncology patients. Studies of women with peripartum cardiomyopathy demonstrate that African American women have more severe disease profile, including younger age at onset, more severe LV dysfunction at age onset, and more severe and lower rates of LV recovery. In a study of 220 women with peripartum cardiomyopathy from a single center, African American women were less likely than non-African American women to recover their EF to greater than 50%. Among those with EF recovery, the rate of recovery was twice as slow despite equivalent ACE inhibitors and beta blocker use. So now moving on to cardio-oncology. The hereditary form of transthyretin-related cardiac amyloidosis disproportionately affects African Americans. The mutation is carried by up to 5% of African Americans. Despite this widespread recognition, not many of the African American patients undergo genetic testing in routine clinical practice. This may be due to the high prevalence of co-occurring disorders that mimic LVH, such as hypertensive cardiomyopathy. However, because there are increasing number of novel therapies being studied for the treatment of TTR cardiac amyloidosis, rapid diagnosis is imperative. So disparities in medical therapy. Guideline-directed medical therapy for heart failure is rapidly changing. There are novel therapies including angiotensin receptor, neprilysin inhibitors, and SGLT2 inhibitors that show improvements in morbidity and mortality. Current guidelines for the treatment of stage C heart failure with reduced ejection fraction also includes the use of combination therapy with hydralazine and isosorbide dinitrate as a class 1 recommendation as depicted in this figure. Despite all the evidence that supports this, there is very, very decreased use of this combination therapy in African Americans. The concerns that most providers have is the 3 times daily dosing and adherence. Despite this, the underutilization of this therapy is more profound than the concerns. Disparities in advanced therapies. There are also disparities noted in therapies including left ventricular assist device and heart transplant available to African American patients. Although the number of African American patients receiving advanced heart failure therapies appears to be growing, this is not proportional to the number of African American patients affected by heart failure. A recent analysis of the Interagency Registry of Mechanically Assisted Circulatory Support indicates that LVAD implementation rates for African Americans did not increase proportionally with increases in heart failure incidence. In the figure, it is clear from graph A that African Americans depicted in the blue line have a greater incidence of delisting or death because of lower rates of LVAD implementation or heart failure transplantation. And in graph E, it's depicted that outcome being transplant is lower, the most lowest in the African American population. So we've discussed the problem, we've discussed the incidence in specific populations and landmark trials. Now, why does this occur? As demonstrated in this figure, the reasons are multifactorial. We will explore the individual reasons, the impact of neighborhood environment, and the impact of healthcare system and policies, each in detail. Genetic makeup also contributes to increased rates of this condition. We'll explore this as well. So the pathophysiology of why. Multiple prior studies have shown that African Americans have impaired endothelium-dependent vasodilation compared to Caucasians. Endothelial cells of African Americans generate more oxidant stress and appear to lead to enhanced inactivation of nitric oxide. This can contribute to more severe hypertension. In the atherosclerosis risk in community study, it was proven that there was a greater degree of arterial afterload in the African Americans population compared with Caucasians. This was measured as higher systemic vascular resistance. There's also a greater deficiency in multiple studies noted of natriuretic peptides and greater salt sensitivity and blood pressure control observed in the African American population. Why else does this occur? On the community and policy level, there was a strong correlation between worse results and no insurance. Compared to Caucasians, African Americans have higher proportions of hypertension, more comorbidities, and higher levels of underinsurance. Within those who are insured, African Americans have higher proportions of Medicaid. From multiple studies, it is apparent that there is a negative bias towards patients with Medicaid. Despite this, social status strongly confounds race and ethnic associations with cardiovascular disease. The higher hospitalization burden among African Americans and Hispanics is more reflective of underlying determinants of health rather than genetic or physiologic differences like we discussed before. This brings us to another important point, the importance of regional socioeconomic status. Poor neighborhood conditions are stronger risk factors for rehospitalizations in congestive heart failure than individual socioeconomic status. Disadvantaged communities may have poor outpatient care or lack resources for acute care services, thus increasing the risk of using acute care services repeatedly. Environmental factors can also negatively impact patients' ability to engage in healthy behaviors. There's multiple studies that have demonstrated low income and predominantly African American neighborhoods having fewer supermarkets, decreasing the availability of fresh, healthy foods. Implicit bias. So this refers to unconscious attitudes or stereotypes that involuntarily affect our understanding and actions. Prior studies we discussed have shown how implicit bias can affect the clinical decision-making of healthcare providers, including the acute care of African American patients with heart failure from the emergency department to the ICU. In a notable study following over 12 million adult visits to the US emergency departments with a chief complaint related to heart failure, African Americans were less likely to be hospitalized than Caucasians, even among older and sicker patients. Another study noted that African Americans and Latinx patients with heart failure were 9% and 17% less likely to be admitted to a cardiology service, despite care from a cardiologist having better outcomes. Similarly, another study with 100,000 patients noted that African Americans admitted to an ICU were less likely to be seen by a cardiologist during their stay. About 422 advanced heart failure clinicians were involved in a Think Aloud interview where they were presented a clinical vignette of an African American patient with end-stage heart failure. There were many notable concerns expressed during these interviews. There was greater concern for adherence in the African American patients and a greater concern that this patient was sicker, ultimately this patient was less likely to be offered heart transplant and more likely to be offered an LVAD. These findings are notable, especially because they're supported in multiple studies. Since the causes for the existence of health disparities are multifactorial, the solutions will need to be multifactorial as well. From the individual level to public policy, each factor can be viewed as an opportunity for intervention to reduce disparities. This model emphasizes the multiple levels of influence that impact patients' behaviors and clinical outcomes. Let's go into detail about the specific components. Solutions on the clinical level. What can we do as the patient's provider? Traditional clinical trials and treatment guidelines focus primarily on the individual patient. Focusing on the management of individual cardiovascular risk factors, particularly hypertension, obesity, and physical inactivity, continues to be one of the most important strategies to control the incidence of heart failure in African American patients. In addition, increasing clinician awareness that African American patients with significant left ventricular hypertrophy, especially if this is in the setting of well-controlled blood pressure, warrant investigations to rule out cardiac amyloidosis. Encouraging minority patients to participate in clinical trials is also very important. Identifying potential barriers for novel therapies should also be made a priority, and encouraging family-based genetic counseling and building strong interpersonal bonds will allow for frequent education, discussion of heart failure severities, and care plans such as medication costs and device therapies in the setting of advanced heart failure. To further dive into the topic of patient education, specifically, patients with heart failure do better when aware of their disease process and self-management strategies. Due to implicit bias, less access to specialists or higher level care, and greater distrust in these populations. There are multiple reasons for cardiovascular racial disparities. Perhaps a less consistent and effective effort is made when engaging race ethnic minority patients to ensure understanding of the care plan upon discharge or outpatient follow-up. Adequate control of hypertension and volume status are critical to the clinical management of heart failure. For race and ethnic minorities and African American patients especially, targeting known risk factors such as hypertension, diabetes, and obesity may be critical to both preventing and managing congestive heart failure. Solutions on the systems level. There are ample opportunities for improving coordinated care of African American patients with heart failure. Algorithms embedded in the EMR could be useful, such as implementations of various quality metrics, including the screening for genetic causes of cardiomyopathy based on clinical criteria, such as the severity of LVH to screen for amyloidosis, automatic inpatient cardiology consultations based on prior hospitalizations and 30-day readmission risks, medication adjustments to ensure GDMT is being prescribed, and on a more organizational level, making sure that clinicians undergo implicit bias training. Although changes at the community level may be outside of the control of the healthcare provider, clinicians must be aware of the unique challenges present for patients who live in socioeconomically deprived neighborhoods. Voucher programs have been successfully used to improve patients' access to healthy foods, cardiac rehab programs, recreational exercise facilities, and even increased green space in communities. At the policy level, there are multiple examples of legislation that have resulted in tangible health consequences for African American patients. Since the adoption of the Affordable Care Act, rates of heart transplant listing and LVAD implementation increased for African American patients. The Hospital Readmissions Reduction Program was initially intended to reduce 30-day hospital readmissions by improving the quality of care and enhancing care coordination, particularly at time of discharge. However, there is increasing evidence that this actually poses penalty on hospitals that serve minority patients. Ongoing efforts to ensure that these safety net hospitals do not incur penalties from the Hospital Readmissions Reduction Program is important. Also, improving health disparities, research funding, and reducing financial barriers to novel therapies is also important. Successful implementations. There are multiple examples of successful implementations. The produce prescription program by Trapanol was used to increase produce consumption in African American patients with hypertension. It was noted about 86% of these patients visited a farmer's market to purchase produce using their vouchers. At the end of the follow-up period, there was significant improvement in fruit and vegetable consumption and a decline in fast food consumption. As stated before, since the adoption of the ACA, rates of heart transplant listing and LVAD implementation have also increased for African American patients. Then finally, Carnithanol proposed several methods used by the NIH to improve funding rates for health disparities research, including diversifying the pool of peer reviewers, involving health disparities expert on every study section, and designating a proportion of funding within the NIH to address specific health disparities topics. Here are further resources for learning about the effects of healthcare quality, access, and delivery to low-income patients. Thank you again for this opportunity to discuss a topic that is very dear to me. Here are my references. These are my acknowledgements. Thank you to everyone for their excellent mentorship and support. Here's my contact information. Thank you.
Thank you, Sona. Next up, we have Dr. Erin Pruitt, and we'll have questions about both talks. We'll have time for questions about both talks at the end of Dr. Pruitt's talk. Dr. Pruitt is a self-described simple country doctor, but he is so much more than that. He's from Somerset, Kentucky, did his undergraduate studies in medical school at the University of Kentucky for studying biochemistry. Now he's finishing up his internal medicine residency here at WashU, where he has been in the primary care internal medicine track. And staying true to his roots, that is very much an interest of his, though he's pursuing hematology oncology fellowship. He has a strong interest in prevention and early detection of cancers, and that is what he will be talking to us today. Please welcome Dr. Pruitt.
All right. Thank you so much, Stephanie, for the introduction. Thank you, everyone who was able to attend online today. I'm going to go ahead and remove my mask if that's okay. So yeah, I'm very excited to talk to you today about a topic I'm passionate about, which is early onset colorectal cancer. In lieu of the more traditional clinical case to start grand rounds, I'm going to provide a case that was a little bit shocking when the news broke. And that's the case of actor Chadwick Boseman, who was renowned for roles such as Jackie Robinson, James Brown, and of course, the king of Wakanda himself. You can imagine how this could play out in a clinical case here in the hospital. You have a 39-year-old, relatively healthy man who presents with abdominal pain or bloody stools. He's ultimately diagnosed with stage 3 adenocarcinoma of the colon, and then sadly passes away after 4 years of treatment at just 43 years of age. And celebrity or not, this is a narrative that's becoming more and more common in our patients today. So briefly, some objectives before we kind of get into it. Hopefully we'll be able to describe the changing epidemiology of colorectal cancer. Hopefully we can recognize the clinical characteristics unique to early onset colorectal cancer and compare it to late onset. Hopefully we'll be able to better counsel our patients on the appropriate screening recommendations and modalities available to them. And lastly, I'd like to identify a few areas for improvement in the holistic care of young adults with colorectal cancer and young adults with malignancy in general. So let's start by defining early onset colorectal cancer. And it's simply colorectal cancer diagnosed in patients younger than 50 years of age. And this probably jumps out because prior to just a year or so ago, this was the cutoff for recommended routine screening in patients of average risk. And so briefly, a word on colorectal cancer in general. It's a very common problem. It's common cancer. It's a common disease in general. Has the third highest incidence among cancers worldwide and in the US, and the second highest mortality. And a few numbers there from 2020, just to kind of put with those statistics. But it's definitely a public health concern. And despite that, we've not done all that terrible a job in the vast majority of patients. And so this is showing incidence rates in patients over 50, broken down by a couple of age groups, so 50 to 64, and then older than 65. And in general, we've done a pretty good job. A little bit of a lull here in kind of the 20 teens with our 50 to 64 age group, but in patients older than 65, where the incidence is highest, we've actually done a pretty good job. And this is attributed to routine screening for colorectal cancer. And how this has played out is about a 35% overall decrease in incidence in colon cancer, colorectal cancer since 1995. What does this look like in that early onset population? So patients who are 49 and younger. Well, unfortunately, the story is a little bit different. And though the absolute incidences are much lower, as you can see, as we would expect, this trend is a little bit troubling. We've seen a pretty consistent increase in incidence since the late 90s in this 49 and younger population. And so the incidence has nearly doubled in that time in patients ages 20 to 49. As a result of that, we've seen the median age at diagnosis for colorectal cancer in all comers go from 72 in 2000 to 66 just 20 years later. And another way to say that is 10 to 12%, or roughly 1 in 10 new colorectal cancer diagnoses will be in someone who's 49 years old or younger. And so we'd be remiss if we didn't also talk about mortality, which is certainly probably what matters the most. And again, a similar trend here in our late onset folks. We've done a pretty good job going back to the 1970s, and this is attributed to both screening and improvements in treatment and supportive care. And comparing this to our early onset age range, you can see that there has been some improvement in general compared to, when this data was first collected in 1970, that's kind of bottomed out and now started to increase some. So improvements from improvement in treatment and supportive care. And then you can kind of see that, unfortunately, the increased incidence we've noted as of late is starting to outpace improvements in care of these patients, resulting in an increased overall mortality. And one last way to kind of demonstrate this changing epidemiology, Caitlin Murphy and her group used some early data from the first SEER registries to essentially model relative incidence of colorectal cancer based on birth cohort. And you can see here that for folks born after 1960 or so, the relative incidence has increased pretty dramatically going forward to the 1990s, which is an important time period for many of us in this room. And so you might wonder, well, this is definitely a thing. So what can I look out for on the wards or in clinic? What does this look like clinically? Is there anything unique about it? And there does seem to be some unique characteristics of early onset disease. So it has a predilection for the left side of the colon and the rectum. So about 70% will be left-sided disease, so rectal cancer or distal colon cancer. compared to a pretty even split amongst distal and proximal disease and late onset patients. And there really is a predilection for the rectum, even beyond the distal colon. So the greatest increases that we've seen are in rectal cancer specifically. Unfortunately, it is a hallmark that these patients tend to have more advanced TNM staging at diagnosis. And a higher proportion are going to have inherited syndromes, for example, Lynch syndrome or familial adenomatous polyposis. And I will just note that it's not that these are getting more common in and of themselves. It's just that patients with those genetic syndromes do tend to present at an earlier age. So this graph shows that, as we kind of mentioned, the most dramatic increase has been amongst white patients with rectal cancer. And rectal cancer in Blacks is not far behind and is increasing in incidence and quite prevalent. Distal disease is also increasing. And then proximal disease, interestingly, is kind of a wash, a slight increase among our white patients with a slight decrease among our Black patients with proximal colon cancer. And this is a comparison, some pooled data with the red circles representing 1992 to 96, and then jump forward to kind of after this increased incidence started, with the blue circles representing 2010 to 2014. And so the next thing we mentioned is advanced presentation or increased stage, TNM staging at presentation. And while the concern is certainly that this represents a more aggressive tumor biology, and that's certainly a possibility, it's not the only thing and probably not the main thing at play. So a couple of important factors in this are, one, the relative decrease in stage at diagnosis for our later onset patients owed to routine screening and earlier detection of cancer. And then probably the most important is delay in diagnosis for our early onset patients. And I thought this study from ASCO just this past year highlighted these diagnostic troubles quite well. So the authors surveyed just over 1,000 patients who were under 50 years of age, so that early onset group, and they found 62% of patients waited at least 3 months to seek medical care. And the range on this was 3 months to over 12 with a median of 6 to 7 months. And that's before even trying to get in to see somebody. So you can imagine how a cancer could progress, especially an aggressive one in that time period. Over half were misdiagnosed. Granted, this is patient reported, so tough to say exactly what that means. And then they also reported that the majority received more than one referral prior to a correct diagnosis of colorectal cancer. And then maybe most striking of all, 77% were diagnosed at stage 3 or 4 disease. Then moving on to our inherited syndromes that we had mentioned. And so you see here that broken down by age, the younger patients, so specifically our groups, age less than 50, the early onset folks, have a higher proportion of genetic syndromes contributing to their disease, which is expected. And folks who are 35 or younger, over a quarter are going to have some inherited condition that is, can account for their colorectal cancer, with Lynch syndrome being by far the most common. And a pretty substantial portion of that younger than 50 group is going to have a genetic condition, germline mutation of some kind, and Lynch syndrome, again, being the dominant mutation or set of mutations found there. And then when you get to late onset disease, so over 50 years of age, it's still about 10%, but much less than in our younger patients. And I apologize, this was the right way around on my computer. So bear with me here, but we'll walk through it nonetheless. I think this is how it looked when I studied step 1 as well. And so this is just the classic adenoma to carcinoma pathway. And really the only reason I wanted to highlight this is because if we're not seeing some dramatic uptick in Lynch syndrome rates, for example, then sporadic disease is really what's driving the increased incidence of early onset colorectal cancer. And so you kind of see here, classically, we have derangement in the Wnt signaling pathway, most commonly APC gene mutation leads to adenoma. And we take one of two pathways, most commonly this chromosome unstable pathway that culminates in TP53 mutation, and finally adenocarcinoma. And then occasionally you can get mutation in these DNA mismatch repair genes that are mutated at the germline level in Lynch syndrome, and get what we call microsatellite unstable adenocarcinoma of the colon, which just means it has a lot of mutation and is prone to getting that. So the only point in having this here is that there are a lot of potential places for things to go awry from the mutation perspective in the development of colorectal cancer. So natural next question is, well, is there some kind of unique mutation profile or signature for our early onset folks relative to those with later onset disease? And if you review the literature on this, it's a little hit or miss. There are some things that do tend to pop up as being more or less prevalent. So more prevalent, you might find studies that say TP53 mutation, mutation in the beta-catenin gene, line or long interspaced nuclear element hypomethylation. And then MMR deficiency, though this is with a big caveat, because if you exclude those folks who have Lynch syndrome, the rates are actually pretty similar across age groups for MMR deficiency. And then less prevalent, you might see less KRAS mutation, less specific BRAF V600E mutation, APC mutations. And I will say all of this should be taken with a large helping of salt, because at the end of the day, a lot of these differences are small on the absolute level and not super reproducible across studies. So unfortunately, we're left with this situation, which is early and late onset disease end up being remarkably similar entities, at least at the molecular level. And so if it's not some super secret mutation that's causing this, what is? And I think that's the $1,000,000 question. And I'm not going to offer you a specific answer today because I don't have one. I think it's complex and you know, as so many things are, multifactorial, involving a combination of genetic factors plus environmental exposures that are sort of aggregated over the whole lifespan and result in a cumulative risk for colorectal cancer into adulthood. I will note that if you recall the birth cohort data that we looked at, an interesting place to start is kind of what was changing in terms of exposures at the time we started to see the increase in incidence by birth cohort, so 1960s and 70s. And some things that jump out are included on this diagram. Changes in the standard American diet to include more processed foods, more added sugars, the advent of high fructose corn syrup, those things all come into play. Additionally, interestingly, increased use of broad spectrum antibiotics, particularly to treat kind of minor infections in children, is something that is brought up in the literature over and over again. Increase in sedentary lifestyle, decrease in physical activity. These things kind of all culminate to produce these disease states that we know are increasing risk for colorectal cancer in patients of all ages: metabolic syndrome, type 2 diabetes, obesity, and in particular, childhood obesity has increased substantially, nearly 200% in the last 2 decades. And so when we think about patients with early onset disease, it's really important to think about what factors, what exposures are happening in childhood and early life that might be affecting our patients well before they make it to our clinic, because we know that it takes time for these things to ultimately result in carcinogenesis. And so what can we do? Well, kind of the same things we're already doing, and that's counseling on a healthy lifestyle as much as we can. So recommending that our patients avoid things like this, added sugar, recommending that they are active, so avoiding sedentary lifestyle. And physical activity, conversely, is going to be helpful in preventing and decreasing risk of colorectal cancer at all ages. And for what it's worth, in the Nurses Health Study 2, despite statistically correcting for differences in physical activity and obesity, they found that, unfortunately, increased sedentary television watching was independently associated with an increased risk of colorectal cancer. So if you were looking for the motivation to cancel that subscription, you are welcome. So we know this is happening. We know this is not good. Shouldn't someone do something about it? And in fact, someone did. By someone, I mean the United States Preventative Services Task Force. And so just last year, 2021, they updated their recommendation for colorectal cancer routine screening to include patients 45 to 49. This is following a similar recommendation in, I think, 2018 from the American Cancer Society, where they made a similar recommendation to include those folks as well. And so anyone who's worked in the Center for Outpatient Health resident clinic recently knows that we are definitely pushing this, and that's a good thing. So briefly, I'd like to review the options we have for routine screening. So colonoscopy, the gold standard, every 10 years, as long as things are normal. CT colonography every 5 years can be done. It's an option. Stool-based DNA testing in the United States, that's branded as Cologuard, every 1 to 3 years. And then FIT testing or stool guaiac testing every year. And then lastly, FlexSig with FIT testing is still included in the guidelines. I'm not going to talk as much about that. And so if we compare, these are all things, as we know, that if they're ever abnormal, you can't pass go, you have to go straight to colonoscopy. So comparing these head to head, certainly it's understandable why colonoscopy is the gold standard, particularly, for detecting precancerous lesions. And that's really the added benefit that you get in addition to just an increased sensitivity. You can find adenomas and pretty small adenomas early and nip those in the butt before they become problematic. But these other modalities are certainly effective screening tools as well, and things that we should consider in our patients. I will point out, all of these things are compared to colonoscopy as the gold standard, even colonoscopy, which is compared to a second colonoscopy shortly after when generating this data. So take that for what you will. And then additionally, when comparing FIT testing to FIT DNA, this was actually just a one-off comparison. And so it's unclear how the 3-year interval versus the 1-year interval might affect the sensitivity differences in those tests. But if you're a Star Wars fan like me, you might say that the Mandalorian would say, with regard to colonoscopy, this is the way. See, that would land if you were watching this one. But I would have to agree with him. It definitely is the gold standard for a reason. But then you also have some people like Dr. Alvin George, who's saying to me, Aaron, I haven't even started GI fellowship yet, and my clinic is already backed up 10 years for colonoscopy. I've got no room in the procedure suite. How are you going to add another 5 years worth of patients for me to do colonoscopies for? And I do understand where Alvin's coming from, but I think that a healthy dose of practicality can help us here. And so before we start worrying about overwhelming the procedure suites, it's important to note only about 68% of eligible patients undergo screening in the first place. And this is a big target for improvement, especially for those of us in the primary care clinics and doing general medicine. We really, really should be trying to get this up. And one strategy to do that is the old adage, the best test is the one the patient will do. And this, I would say, is very, very true. And I think you've all probably noticed the patients are definitely willing to consider those less invasive options. I will say that this applies to those folks who are undergoing routine screening for average or modest risk. And so one thing we can also do to kind of help make this decision is risk stratify our patients as best we can. Even using something as simple as just a good family history. So you can see here the guideline recommendations for when to do colonoscopy at 40 years old instead of 45. And that's if you have a first-degree relative who is diagnosed at 60 or younger, or 2 first-degree relatives diagnosed at any age. And some interesting data from 2020, Gupta et al., they found that 25% of patients who were diagnosed in their 40s with colorectal cancer would meet criteria for this particular screening. And that's huge. If we could catch 25% of those patients at a point where they have curable disease or even pre-disease, that would be absolutely amazing for our patients. And so we've talked about screening, we're doing age-appropriate screening, and we're likely catching some people. We've probably made a diagnosis of early onset colorectal cancer at this point. Now what do we do? Well, I want to talk about something I'm really excited about, which is something upcoming here at WashU and Simon Cancer Center, and that's a dedicated early colorectal cancer program. And these are kind of popping up across the country. A few other institutions have already implemented something similar to this, but I'm really excited for this one because it's going to allow this patient population to get the care that they need. But also I think it serves as a really excellent model for us as generalists to sort of go about caring for these patients and shows how we can be helpful in their care, even if we're not prescribing chemotherapy, for example. And let's go through some things that are going to be included here. So every patient who enrolls in the early colorectal cancer program will get an automatic referral to medical genetics. So they and their family will both undergo germline testing for any potential familial mutations, automatic palliative care referral for unresectable disease, referral to the Living Well Center, which is a super great resource we have here, focused on nutrition, physical therapy, overall health, and is going to be tremendous for patients who are undergoing tough therapy. Behavioral health counseling through the Simon Counseling Center. And then not quite effective yet, but a goal is on-site childcare, as it's a pretty common complaint amongst young adults with malignancy undergoing treatment that they might have difficulty arranging childcare for frequent infusions and things like that. Some other important factors to consider with young adults, not just with colorectal cancer, but malignancy in general, that will also be addressed in the early colorectal cancer program here, fertility counseling and sexual health concerns. And these are really, really under-recognized, not just under-recognized, but under-counseled about and under-intervened upon. And I just want to highlight some data from a systematic review that came out last year, where 70% of patients report that they felt they were not adequately counseled or prepared for possible fertility side effects and sexual side effects related to their cancer itself and therapy for cancer. And so part of the program is going to be early referral to our colleagues in reproductive endocrinology, gynecology, urology. And these are things that we can watch out for in the primary care setting as well. And just start that discussion, make sure we're asking patients about these things and that we're quick to get help for them if they're having those issues. So a few take-home points when it comes to combating early onset colorectal cancer. I say take red flags seriously at any age. So hematochezia, undiagnosed, unexplained iron deficiency, weight loss. These are things that should really not be kind of blown off as some other diagnosis right away in younger patients just because of age. So I think that, after this talk, hopefully we'll all think a little bit more critically, not that we have to do the $1 million workup on every patient who has one of these complaints, but we'll at least kind of take the time to think about how the epidemiology is changing and how it might change the likelihood of them having a serious diagnosis. So talk early and often with your patients about current screening recommendations. It may not be time for them yet, they may not be ready yet, and that's fine, but we should be bringing this up as often as we can. And clinic visits get crazy busy, but whenever you have the chance, it's definitely an important topic to bring up. And again, the best test is the one that they'll do. Regularly update family histories. This is a new one for me and something I'm going to have to incorporate into my own practice, but it really does inform risk prediction and can help us make decisions. And this is going to constantly be changing. You might start your care of somebody intern year, and by the time you're a PGY3, they've had 2 uncles diagnosed with colorectal cancer and a brother or something. This can change, and I don't feel like often enough we reevaluate the family history. And then effectively treat diseases we know are associated. So IBD kind of out of our wheelhouse, but diabetes, obesity, these are diseases we treat all the time and have great new therapies for that can definitely help patients and decrease their risk. And then addressing modifiable lifestyle factors like we always do. And as far as future directions, I'm hopeful that in the not too distant future, we'll have even better risk stratification models than we already do that incorporate genetic data, environmental exposures, and risk factors to kind of better inform who to screen early and how regularly to screen patients at a personalized level. Ideally, we'll continue to get more accurate, more accessible, cost-effective modalities for screening, and whether that's improvements in the stool-based tests or novel things like circulating tumor DNA, but whatever it is, as long as it improves our ability to detect disease at an early curable stage, I'm happy with it. And then better understanding of the pathogenesis of the disease, including potential targets for intervention and early intervention at that. And then lastly, something that we can do right now, and that's broad implementation of a holistic approach to care of young adults with colorectal cancer. So I would like to thank Dr. Ranha for kind of kickstarting the idea for this talk for me, Dr. Katrina Peterson, who is kind of one of the folks heading the development of the early colorectal cancer program here and was really instrumental in mentoring me for this talk. Dr. Schmidt, Dr. Costco, all the chiefs, my co-residents, the PCIM squad, many of whom are unfortunately taking the ITE today, but shout out guys, and of course my wife and Winston and Baxter for their contributions. And I guess with that, we'll do questions for both of us.
Any questions for either Eric? Millie?
I have a question for Erin. Going on like insurance and affordability of all of this stuff. So say you have like a patient that's like 20, 30 years old in your code clinic that has these symptoms. I don't know if you know this, but do you think like insurance coverage is an issue with this, like getting insurance to cover colonoscopy? And if a patient doesn't want that, I feel like even for some of our patients that have Medicaid and things, getting like the CT or FIT testing is still like cost prohibited and maybe the insurance doesn't cover it. So do you think that's an issue for these early age groups?
Yeah, I think it's a big issue. I think that depending on what the symptoms they're presenting with are, there are some diagnoses codes that you can get coverage for colonoscopy, even in the Medicaid population, provided it's, an approved indication. And so I think that just being, a little strategic in that, if we're getting the appropriate billing codes, something like recurrent hematochezia or severe iron deficiency anemia, I think those things can potentially get covered. With more subtle symptoms, it could definitely be tough and it's probably not going to be routinely covered. As far as the stool tests, I'm not 100% sure if the same applies there. But again, if you're having someone with active symptoms, that, like you were saying, clinically, the right thing is probably to try to go directly to a direct visualization. Yeah,
sure. So you're describing screening as basically becoming part of every human being's life. And so it is going to require a ramping up of our screening capabilities. You mentioned, the clinics are overwhelmed. In other countries, they have addressed this through using advanced practice clinicians like NPs or PAs doing these routine tests on a more industrial scale. Has there been any consideration of that here in the US?
So what I've found, it's definitely been proposed. There was a really recent review from a gentleman out of Memorial Sloan Kettering. I'm blanking on his name, but where they did propose something similar to that. As far as implementation, I haven't seen anything just yet, but I think it's, something's going to have to be done. So yeah, I think it's a really good strategy. Dr. Schmidt, did you have a question?
Yeah, so I think that that's an amazing program, this early colorectal cancer screening or cancer program. My question is about palliative care. So data has shown that earlier intervention with palliative care, regardless of the stage of disease, improves outcomes, quality of life outcomes, survival outcomes. Why is it just for people who have unresectable disease? Is it a resource issue, just like pragmatically, or?
I think it's partially a resource issue because in folks with unresectable disease, the idea is that is happening from their intake into clinic, and they're already kind of being set up with that person. This is all going to be done very quickly upon entrance to the program. Whereas, if someone with earlier stage disease, resectable disease, expresses an interest in that, or the clinician identifies a need for that, they can certainly refer them later. It just won't be kind of that auto enrollment process. Yeah. Yes, sir.
I have a comment regarding the first talk. Oh, there she is. Okay. I saw in a couple of your slides you had hydralazine as a possible drug to treat the hypertension, and I'm a rheumatologist, and we put a stop to that medication completely in the 70s and 80s here. In fact, we had control of whether or not you could order that prescription because of all the side effects we were seeing. At that time, we didn't have many other treatments for the hypertension, but now we have others, and I would strongly recommend that not be used because of the side effects, particularly in the African-American population of lupus and so forth, secondary effects. As you may know, the VA here did a beautiful study in the 70s that was published regarding all the side effects of hydralazine, and that led to most of us stop it being used. So I don't know, but I see it coming back in the cardiology group again, and I would have put a negative on it. But so anyway, just something to consider. I what you read about the use of hydralazine, and I see it coming back again.
So that's really interesting. Thank you for bringing that up. I think what I read so far, I think it was by Dr. Khadija, who did a study particularly looking at the effects of the decreased bioavailability of nitric oxide, and hydralazine works synonymously with isosorbide dinitrate to increase that bioavailability. But I haven't specifically looked into the side effects like lupus, which would be something interesting that was be more prevalent in that population. So that's good to know. Yeah, thank you.
All right, thank you very much.